Welcome to another edition of Nurse Minute. My name is Brenda Marks. It is my pleasure to welcome Jim Gauthier, Senior Clinical Advisor for Infection Prevention at Sealed Air Diversey Care. Jim has a 35-year background in healthcare, having worked for many years as a medical laboratory technologist in microbiology, and brings 25 years of clinical experience as an infection preventionist in acute care, long-term care, as well as mental health settings. Jim has consulted with many healthcare companies and is also an adjunct lecturer at Queen's University in Kingston, Ontario. Welcome, Jim.
Thank you very much for the introduction, Brenda.
Jim, we have a few questions for you today, and I guess my first question would be, in your opinion, what is the proper way to clean a patient mattress?
The proper way to clean a patient mattress would be to make sure that, first of all, you're using a compatible product with the mattress cover. I think many of the issues I see in cleaning of the healthcare environment is utilizing something that is not appropriate for the surface that you're trying to clean. The mattress obviously should be stripped down and inspected before any cleaning to make sure that there are no breaches in it or holes, rips, or cuts. If holes, rips, or cuts are discovered, you should check the integrity of the foam or the lining inside the mattress cover to make sure that no body fluids or other solutions have made it into that part of the mattress. Then once we start cleaning the mattress, we would obviously ensure that all surfaces are in contact with the disinfecting agent and left on the mattress for the appropriate contact time as recommended by the manufacturer. If that contact time is going to be exceeded, you would want to make sure that the mattress is dried after the appropriate contact time so that no moisture would pool on the mattress cover. The last point I would point out is as you clean the bottom of the mattress, that surface should be dried before it is put back down so that, again, you're not trapping moisture or leading to other issues that could come from a wet mattress sitting sealed on top of the bed surface.
Okay. So here's a question for you, Jim. In your role as an infection preventionist, what would you say would be the biggest differences between acute care or long-term care settings?
Well, that's a good question, Brenda. A lot of it is basically the acuity or the level of illness that you see, and then the length of stay.
And were there any differences, let's say, I know there may be differences in the types of beds they use, but have you seen any difference in the actual types of mattress covers you would see in either of these settings?
No, I have found that the actual mattress covers tend to be fairly consistent. It's just the variety that you will see depending on what the actual bed is used for. Air fluidized bed where you have different structures inside the mattress may have a different cover on it than your regular run-of-the-mill patient bed. But in general, most mattress covers I have found from both acute care and non-acute care are fairly consistent in terms of being fluid resistant so that moisture doesn't leak through.
Okay. And have you noticed any differences in, let's say, the EVS staffing or the training between acute care and long-term care?
That really does depend on the facility. I found that all EVS staff do need adequate training for their positions. In long-term care, you're not going to have the kind of training that you would find in a critical care area where they need to be instructed on the numerous different medical devices that may be in the patient environment. Also, the depth of your daily cleaning, I have found, may vary depending on the patient care area. So in a nursing home or a more long-term care stay, you may not see the same level of cleaning that you would get in an acute care room on a daily basis.
And what about different cleaning methods or disinfectants used? Do they both, in long-term care and acute care, start at the head of the bed and work their way down, or have you seen any differences in that regard?
Oh, I've seen differences, and I've definitely heard of differences. We always strive when we're doing training with our clients that we would teach the EVS staff or audit them to start from top to bottom, so that if you dislodge any, say, dust at the higher level, it would be picked up at the lower level, to always work from a clean surface to a more dirty surface, and to also work in one set direction around the room, be that clockwise or counterclockwise, so that if you get interrupted, you know that the surface has been cleaned. In terms of different disinfectants, it will vary by facility. some facilities may tend to use more of a cleaning agent or a sanitizing agent on a daily basis until they see a problem such as norovirus, an increased amount of vomiting and diarrhea. Then they may switch to something with a disinfectant claim for killing something like norovirus.
So here's a question for you. Technically speaking, how would you say damaged mattresses can serve as a reservoir for cross-contamination?
It depends really, Brenda, the degree of damage that you're seeing on the mattress. If a mattress has a folded area because they adjust up and down and you've got a crack there, if it's been soiled with feces or with urine, that body fluid will get inside the mattress and has the potential for migrating back up to contact the sheets or the environment around the next patient. With these bacteria inside the mattress, they do have that opportunity to actually hide from the disinfectants. And if the next patient has enough body fluid from sweating or they urinate in the bed, you could see the migration of these organisms back up to the patient's skin. Granted, once on the patient's skin, they still need a portal of entry to actually cause problems in the patient, but it just allows an opportunity for bugs to be transmitted back and forth through these kind of tears.
Okay, so if we were to restore the cover to be intact and fully cleanable, even let's assume fluid had penetrated into a damaged area before it was restored and repaired, how does that impact the cross-contamination potential?
Well, I think if someone is going to repair a mattress, they need to make sure that there's no visible soiling on the inside of the mattress. I think for newly developing tears or stress areas on a mattress, those can be sealed. But if you actually are looking at repairing a mattress, you should inspect the interior part, which is usually foam. And if it's visibly soiled, I would be hesitant about actually then sealing that kind of obvious large amount of body fluid to the mattress core. I think if you look inside and you thought, good, we've caught this just in time, and there may be some microscopic amount of bacteria inside, I don't think you will actually see migration back up, especially if you're using a good patch. I think bacteria sealed down inside there will eventually die. We have many microorganisms that can survive for long periods of time. But if they're in an enclosed space like that, I don't think it's going to be a big issue.
Right. Okay, well, I thank you for that answer, Jim. I know it's kind of a confusing topic, and we get asked that question quite frequently, and we're doing our best to dispel some of the myths that we hear. Here's a question for you, I guess, last of all. I'm just curious, as an infection control resource for Diversey, what is the most common question that you get asked?
Probably the most common question is the bug of the week. For instance, today, my bug of the week turned out to be the Zika virus that is starting to show up in Mexico and potentially in some of the southern United States. And immediately there's questions and concerns about the Zika virus and how a Diversey disinfectant would be effective on this virus if it was found on a surface. I find that as new bugs show up or the media harps on a particular bug, I tend to get asked those kind of questions. This also occurs quite frequently about the multi-resistant organisms that we're now seeing in our healthcare setting, and people wanting to make sure that our disinfectant products will kill an E. coli, for instance, that is resistant to numerous antibiotics or that is carbapenemase producing. And it's always the same story that I have to give back, that an E. coli is an E. coli. If it was killed by our product as a sensitive E. coli, it will still be killed by our product as a resistant E. coli. So those are the questions that I tend to get a lot. Our reps we just did some training, and a lot of the information I try to share with my reps is the information around the chain of transmission, what you have to happen, all 6 links to have an infection occur within a patient.
And I wish we had more time. There's certainly never a dull moment in infection prevention, and I sense a part 2 coming up, Jim.
Oh, I think so, Brenda, and I would look forward to doing that with you.
Well, thank you so much, Jim. We really appreciate you joining us today. If anyone has any questions for Jim or myself, please email us at the email address on your screen. And once again, Jim, thank you so much for joining us.
Not a problem at all, Brenda, and I look forward to doing some more of these if you think there's an interest.